I think the issue that's being evaluated currently is the fact that testosterone level gradually decreases with age. And in some men, it decreases more than others to the point where it truly becomes deficient. And so the question has arisen as, is that deficient testosterone something that's pathological, something that should be treated, or is it just part of the normal aging process and doesn't really need to be treated? There are a number of studies that have been done over the years that have looked at this question and raised even the question of possible adverse effects of giving testosterone to older men, so that the Institute of Medicine came up with the concept that we really should address this question carefully. And so they suggested that a trial be done called the testosterone trial, which is what I was a participant in as far as being a principal investigator for the Northwestern component. And this was designed to see whether testosterone supplementation in men over the age of 65 who clearly had low testosterone levels was able to bring the testosterone levels back to normal, which it could, we knew that, but did it cause any benefits for those individuals, as well as looking at some of the adverse effects. So in this study, it comprised 790 men. They were randomized to testosterone given as a topical preparation on the skin to be absorbed into the bloodstream, versus placebo, and then men were followed for a year, and a variety of tests were done in those men to see if there was any benefit. The men also not only had to have a low testosterone level, but they had to have some symptom that would be compatible with testosterone deficiency, such as sexual dysfunction, decrease in muscle strength, bone problems, anemia, decreased vitality, and the like. So they had to have at least one of those characteristics to enter into the study. And so the study was carried out over a year. The men were followed very carefully over that year, looking both at these potential benefits as well as potential risks. And then they were followed for an additional year at the end of the study to look further at those both benefits and risks. The bottom line from these 790 men is that, in fact, there were benefits, as expected, in sexual function, both in libido as well as getting erections, sexual satisfaction. All of those were improved, but they were relatively modest improvements. There were some improvements in walking capacity. That is, if you saw how fast people would walk over 6 minutes, there was some benefit there, but again, they were very modest benefits. There were some slight benefits in vitality, some slight benefits in depression and things like this, but they were very modest types of benefits, but they were all in the right direction, but none of these were really startling benefits. But risks were also looked at. So risks for problems with the prostate gland, cardiovascular issues that were looked at as well, and there were no adverse effects that were seen greater in the testosterone group compared to the placebo group, even in men who were then followed for another year. Now, I should say that the study was not powered to look for adverse events in large numbers of men. There were 800 men in the study, which is by far the largest study ever done in a prospective randomized fashion for testosterone. But you really might not pick up a very subtle difference in cardiovascular events. There certainly was no major thing, that's for sure. And I think that when you put this data together with all the other aggregate data, it really shows that this is a pretty safe type of treatment. That's where the individual clinician comes in. That's when the doctor who's seeing the patient looks at the benefit data and the risk data from the study, as well as other data. They then must make an individualized decision with the patient sitting there in front of them. And remember that all of this is aggregate data for 400 men in each group. And so that means that some men had more benefit and had no benefit. Some men had more risk, but in fact the risks were so low that there really were no real risks from the study, and some men clearly had more benefit than others. So the individual clinician, in looking at a patient, can say, well, maybe there's some benefit for you depending upon your symptoms. Probably there's not really any real risk. You could try it for 6 months or a year, see what happens. If you find beneficial effects, then continue. If you don't, you can always stop. It's not a life-saving type of treatment. I think a general physician can treat this, general internist, primary care physician, but I think the critical thing is to say, I've got a patient who actually has a low testosterone level. It's not going to prove any benefit at all in men who've got normal testosterone levels. So men who have unequivocally low testosterone levels, you also need at least some evaluation to find out why the testosterone is low and make sure that it's just an aging process rather than some pathological process. And under those circumstances, I think that would be an appropriate candidate potentially for treatment. But there are a lot of practitioners who say men come in with symptoms of sexual dysfunction, erectile dysfunction, let's put them on testosterone without even measuring a testosterone. And that's certainly not what this study showed, and certainly not what should be done. Well, there's normal parameters, and the normal range, depending upon the assay, is, for example, between 300 and 800. And so somebody who's unequivocally lower than 300, depending on the assay that's used. Now, admittedly, that normal range was set for younger men. And in fact, that's what our study was designed to show, whether using that normal range for men between the ages of 20 and 40, if you drop below that as you age, is that harmful? Or if it's not harmful, does treatment make a benefit? And in fact, treatment does do some benefit, but it's not dramatic.